Goedemiddag iedereen. Ik denk dat iedereen mij verstaat, jawel. Detoo Architects, even voorstellen. Wij zijn een architectengroep met vestiging in Oostende, in Destelbergen en in Singapore, sedert vorig jaar. We hebben een voorname focus op projecten in onderwijs en in zorg. Detoo is eigenlijk een overkoepelende naam, is een holding in vennootschapsstructuur. Boven twee lang bestaande architectenbureaus, namelijk Boeks Architects uit Oostende en de Vloed Architects uit Destelbergen. Samen hebben wij besloten, intussen 3 jaar terug, om de krachten te bundelen en om onder de nieuwe naam, alhoewel dat de 2 merknamen ook nog dagdagelijks gebruikt worden, maar om toch naar de toekomst toe onder de nieuwe naam Detoo Architects naar buiten te komen. Zoals ik zei hebben wij heel veel ervaring en een sterke reputatie opgebouwd in de projecten voor onderwijs en voor zorg. En zoals u kunt lezen hebben wij hier en daar ook wel wat aandacht voor zaken die voor een bouwheer nogal belangrijk zijn. Wij kijken namelijk altijd voor wie we gaan ontwerpen. En daar houden we rekening uiteraard met alle vereisten die gesteld worden door die bouwheer. Vandaar ook onze subtitle onder onze naam. En Detoo zelf komt van Design to Operate, waar wij zowel het woord design in de zin van vormgeving, het ontwerpen op zich, maar ook het esthetische heel belangrijk vinden, maar waar wij ook het begrip operate even belangrijk vinden. Wij zijn gespecialiseerd in projecten waarin geleefd, gewerkt, geleerd, geslapen, verzorgd moet worden. En daarom vinden we ook wel dat het gebouw ontworpen moet worden waarvoor het dient. Oei, ik ben op het verkeerde knopje aan het duwen zeker? Ja, waarschijnlijk. Voilà, daarom hebben wij dus zowel luisteren wij naar de vragen van de bouwheer en geven wij daar een gepast antwoord op. Voor de rest ga ik niet te veel over onszelf vertellen, want ik denk dat het belangrijker is om ook de volgende zaken aan bod te laten. En dat is, zoals Jan gevraagd heeft, waarom Detoo Architects lid is van Prof. Zoals het al aangekondigd werd, zijn we er eigenlijk van in het prille begin bij. Het prille begin ziet u hier, hoera, een baby, is eigenlijk ontstaan hier in het Chinees restaurant in Poperingen, waar Jan mij op een middag uitgenodigd had en waar wij tot de, ik zou bijna zeggen, de conceptie zijn overgegaan, alhoewel dat daar niks lichamelijk mee gemoeid was. Het is niet persoonlijk bedoeld, Jan, maar het was gewoon een brainstorm waarbij bepaalde ideeën eerder dan nog in de zin van ontwikkeling binnen het kader van wonen, maar dat we zeer rap uitgebreid hebben naar een veel uitgebreider gebied, waar Prof intussen al zoveel jaar uit ontsproten is. Wat vonden wij daar belangrijk aan? Dat is een stukje frustratie van de architect altijd, zeker bij openbare aanbestedingen, dat we niet alles in handen hebben en dat we gebonden door procedures soms moeten tevreden zijn met een resultaat waar we het soms wat anders gehoopt hadden. En hier hebben we de kans om inderdaad die concepten te gaan ontwikkelen in samenwerking met gebruikers, met fabrikanten, producenten, scholen, of alle mogelijke mensen worden samengebracht en gaan nieuwe zaken gaan ontwikkelen. En als het nog niet bestaat, dan gaan we wel iets zoeken zodanig dat we het kunnen integreren in die projecten. En dat is hetgeen die ons als architect natuurlijk meer voldoening heeft dan het samenrapen van verschillende elementen. Prof, wat vinden wij ook belangrijk, dat is naast die denktank waar alle groepen in verenigd zijn, dat we effectief concepten maken en dat die ook gerealiseerd worden, vinden wij heel belangrijk, want er staan bibliotheken vol met boeken, met plannen en tekeningen en met zaken die niet gerealiseerd worden. Hier kunnen we erin rondlopen, vinden we zeer belangrijk. En dan uiteraard de zaken die erbij komen, nieuwe thema's die aangesneden worden, de leerstoel die erbij gekomen is, de studiedagen zoals vandaag en nog een aantal zaken in het verschiet. De Jewel is al toegelicht en er komen nog zaken aan. Die zijn voor ons heel belangrijk. Wie hebben wij uitgenodigd vandaag? Dat is Gunther de Graeve. Hij is aangesproken in het Engels, maar hij is eigenlijk van Belgische oorsprong, maar woont al geruime tijd in Australië. Dus hij zal ook zijn voordracht of zijn presentatie geven in het Engels, omdat dat nu eenmaal zijn dagdagelijkse voertaal is geworden. Maar het is nog altijd wel het Nederlands machtig. Hij heeft voor architect gestudeerd. We hebben hem leren kennen omdat hij een passage heeft gedaan op het kantoor De Vloed in Destelbergen bij ons. 2 maal 1 jaar, intussen al geruime tijd geleden, voor de liefde hem andere oorden in deze wereld hebben doen opzoeken. Gunther woont en werkt in de Redlands, de streek Zuidoost-Queensland, waar Brisbane de voornaamste stad van is. Om maar even te situeren. Hij is daar ook verliefd op geworden, niet alleen op zijn vrouw, maar ook op het land blijkbaar. En ik kan begrijpen waarom. Zijn vrouw ken ik niet, ik heb het over het land. Dus, Gunther is managing director of Destravis. Destravis is een consultingbureau, dus Gunther is architect, maar is geen architect meer, of speelt geen architect meer. Zij zitten eigenlijk in de planningsfase, in de conceptfase, in de programmatiefase, dus alles wat eigenlijk vooraf gaat aan een project, daar zijn zij in gespecialiseerd en daar gaat hij het zelfs ook met jullie over hebben. Daarnaast is Gunther ook zeer actief bij de International Academy for Design and Health. Hij is daar director voor Azië-Pacific, dus je moet daaronder verstaan Hans Azië die aansluit bij de stille Zuidzee. En dat zal zijn van Indië tot en met Japan, denk ik. En in hoogte tot aan Rusland. En beneden Oceanië erbij, dus tot en met Australië. Dus een toch wel zeer indrukwekkend groot gebied. De International Academy is gekend onder andere van de wereldcongressen die zij ik denk tweejaarlijks organiseren. Een tijdschrift World Health Design en ook hun Academy Awards die dan uitgereikt worden ter gelegenheid van de congressen. Wat de International Academy is, kunt je nalezen op het internet. En voor degenen die zeer vlug Engels kunnen lezen, ziet je het hier ook even. Even nog toelichten wat gezondheidszorg in Australië betekent. 3 dingen die Gunther mij zei die toch belangrijk zijn voor jullie om te weten om alles in de juiste context te kunnen plaatsen. Dat is dat er in Australië een free health system heerst. Dat wil zeggen free in de betekenis van gratis. Dus alle gezondheidszorg is gratis in Australië. Waar de publieke sector, het tweede puntje is dus waar de publieke sector tekort heeft geschoten, daar zijn dus wel private initiatieven ontstaan. Dus je hebt ook de dualiteit tussen de private en de publieke ziekenhuizen. En het derde dat hij nog wilt meegeven, dat de overheid in Australië dus zowel regulator is als supplier, als zorgverstrekker. Dat zij beide zaken onder de hoede nemen. Voilà, Gunther, ik vraag u hierbij op het podium en geef u graag een half uurtje tijd om uw uitleg te doen. Dank u wel.
Dank u, Serge. En als u mij inderdaad excuseert, ik was gisteren toegekomen in België en was uitgenodigd op een barbecue bij mijn broer. En ik voelde daar zelfs dat ik tamelijk wat naar het Engels aan teruggrijpen was. Dus ik dacht, het is maar beter dat ik bij het Engels blijf vandaag. Dat gaat het wellicht wat beleefder houden. Vandaag wil ik spreken eigenlijk over een paar initiatieven. En ik was gevraagd over de innovatie van de gezondheidszorg te spreken in Australië. En the items that I would like to talk about is why do we need integrated healthy communities? I see that as the main innovator that we've been working on in the last decade in Australia. And there's 2 main benefits. There's a strategic benefit. The strategic benefit is that it actually goes all the way back what the previous speaker was talking about at the project in Holland, about starting to play with new precinct planning, urban planning, ruimtelijke ordening, and starting to integrate the delivery of healthcare and trying to broaden that through those initiatives. The economic benefit out of that is, well, like everywhere in the developed world, we're running out of money, or we have run out of money, and we need to find different ways to fund the system as we know it. And indeed, the consumer being far more demanding, as we call it in our language, isn't going to go away. Even though politicians say, well, we need to have a public debate about this, it's like a bus service. Once you put a bus on the road, you don't take the bus away, because you get the whole population getting up in arms. So saying that you no longer should be doing hip replacements on 92-year-old people, well, if it's your mother or your dad, you're going to have a very different view on that. So I think that is a very unrealistic view, and we need to actually start working about different ways of funding that, rather than just leaving it to, let's have a public debate, which actually never has occurred. And the next thing is about the solution. What are the innovations that we can do, and how can we unlock these? And in a system that is actually controlled by the government, where government both regulates it and supplies it, there's an enormous amount of red tape involved. And how can you cut through that red tape? That is a whole other argument as well. So the first thing, why do we need an integrated, healthy community? Well, just because it's the right thing to do, in my view. What is a healthy community, however? Well, we talked about today this polluting air, natural disasters that are occurring, just slums being developed, and this is developing countries, but also in very rapidly developing countries like in China. Is this all part of a healthy community? We're having the slums still around in Asia. And this is just even an example closer. This is London, the outskirts of London, where we still have these ghettos actually of so-called social housing. Is that really the right urban environment where we think this is a healthy environment? Office environments, the office environments of the 70s and 80s, where we just pigeonhole people. Is this really, again, healthy to spend your whole day in? And then initiatives of building these fantastic 1,000, 2,000 bed hospitals absolutely in the middle of nowhere, where we need to take a car, etc. And then we also talking about the third world, how people still live in poverty just here in our developed worlds. Is that really a healthy environment? Well, if I would talk about this, about safety in design, then we've totally sorted this. We do no longer accept practices on construction like this. We have whole heaps of regulation, and there is a practice of how do we actually now construct these things. There's legislation in all countries around this, so we totally understand what safety in design means. Similarly, we understand what environmentally responsibility of design means. We all now in our design practices take care on the environmental approach, and there's again legal systems around it, standards around it. Every country or either grabs another one or we have them ourselves. So we totally understand this, but we do not understand what is the healthy responsibility of design. Quite a bit of a changing moment for me came when I met this person, which is Professor Ian Fraser. He's an Australian of the Year, which is one of the highest bespoke titles that you can get in Australia. And he also an Order of Australia, which is a bit like a Silver Cross in the UK. He's a researcher. He invented a vaccine against cervical cancer, but his main message was, when I went and asked him to be our patron of the World Congress in Brisbane, that he actually said, "Thank you, I've been waiting for you to come, because my kind of people, which is clinicians, we can actually deal with 30% of the diseases out there, which is the communicable diseases. The non-communicable diseases, however, is something that is organized by all of you who are responsible for the built environments. So we're talking about the urban planners, we're talking about the architects, we're talking about the engineers, we're talking about the manufacturers. We're all in it, and we're actually all responsible for that 70% and the failure of that 70%. So he said, I can't help you with it. I can come up with another vaccine for this, but I cannot fix the urban environment or your bad buildings or your unhealthy workplaces. That is something that you guys need to fix with your industry. And that was really for me a bit of an aha moment. And that is really where the whole thing started off, like, yes, we actually do have a huge responsibility with our design and creating health outcomes. In developing countries, there would be a huge reduction of all of these non-communicable diseases if we actually started doing that. Worldwide, the World Health Organization is estimating it to be 13 million deaths a year that are occurring as a result of this. Now, Canada has done really good research around this, and a couple of findings out of that is that, and a bit like what the maps have been showing in the UK and in the US, etc., that there's a huge pattern between the socio-economic problems health problems and education problems, etc. If you put actually the cards on the maps on top of each other, they're the same labels, the same like red zones, etc. They're just different headings. So socioeconomic status has the same patterns like the health outcomes. Investment in infrastructure and street design have an enormous impact on the economical and physical disadvantaged people. Lower income neighborhoods need to be disproportionately exposed to quite a lot of other bad environments and social environments. And the access to nutritious food is a key component. It's interesting, one of the slides that I took out, since we only have half of an hour, is that, for example, the price of healthy food in the last decade has more than doubled in the developed world. However, fast food has actually been the same or cheaper. So in a lot of these developing or poor areas, it's actually a lot cheaper to buy fast food because they can't afford the healthy food. Even walkability, we actually see that, so the difference on the top there that you see is the life expectancy differences between the well-off neighborhoods and the not so well-off neighborhoods. But an important one is there, the graph on the bottom, where you can see that in the last 40 years, that where we had access, 75% of people had access within 1 kilometer to a supermarket. Now only 20% has access to a supermarket. Now that 1 kilometer is walking distance. Anything beyond that is we're jumping in the car or we drive towards it. So another reason why do we need integrated healthy communities? Because we can't keep affording this. Just from a context point of view, in Australia we're actually probably a bit worse off in the sense that we're so big. We're only having a population of 25 million, which is basically a bit bigger than Holland. However, you can fit Europe twice in the land area that we have. On the other hand, we are extremely urbanized. More than 90% almost of our people live in urban environments. So this huge rapid population increase which we're dealing with, because we're actually still allowing an enormous amount of immigration, and especially when we talk towards the more sunnier states, like the state where I live in Queensland, we're actually having the extreme of that, where we have cities growing by 500,000 people, at least in the next decades. So we're getting a double whammy. We're having actually the aging of the population on the one hand, and we're also having the population increase on the second hand. And I was telling to somebody before who asked me, how big is the average hospital in Australia? And I said, well, they start off the same like here, 150 beds. And then 5 years later, we need to make them 300, 400 beds because that's the population they serve. And now we're making them 1,000 beds because they're no longer on the edge of the city. They're now already in the middle of the city, and they're now covering a population that is a lot more. And because we are already so densified and so urbanized, it also means that there's no vacant spots anymore to double a hospital and to say, well, let's build 200 or 400 or 500. So we end up with these massive hospitals. And the proportion of the population aging 65 and over is rapidly increasing as well. As you can see, by 2050, we're estimating that close to 25% of our population will be 65 and over. So we can't keep affording this. So we started looking at, what would be the benefits be of these healthy integrated communities, and I'll try to define also what these things would be. Well, the first thing is that we said, let's no longer look in urban planning in these activity zones where we say this is housing, and this is education, and this is health, and this is industry, etc. But let's actually start blending all of these together, and when it comes to health, let's actually understand that health needs to be everywhere in the community, and do we actually say this zone on the map is actually what we would call a integrated, predominantly health environment. And that would mean actually that within that area we would be able to have education, we would have housing, etc. So just integrated planning, it's basically like what we call structure planning. I don't know if these things still exist in Belgium, but like bijzonder plan van aanleg, etc. Those are the things that we're talking about. So it really means that government at the highest level can come in, rezone the entire area, and by doing that, actually all the other frameworks are following. So I was talking before about that we can't afford this, and just on another matter here, the expenditure in Australia, similar almost like what you saw in Holland, only we're sitting closely to $150 billion that we're spending, and we're also sitting around the 10% of our GDP that we are spending as well. And only going back to, I think the slide starts here, 1986, where we only were sitting around the 4% of GDP. Our building stock in Australia is probably not that different like many other areas of the developed world. We have quite a lot of buildings of 30 to 40 years still hanging around that are absolutely past their design life and that we really can't reutilize and that we need to start knocking over. We're also pretty much ashamed that the things that we couldn't house, we started putting in these what we call dongers, temporary buildings, and they stay temporary for 30 years, we find out. I've met actually a generation of healthcare workers that they were the only facilities that they ever worked in since graduating of university. Amazing. We're struggling with getting the digital files implemented. It's kind of half-baked, and a lot of that has to do with different levels of government and the red tape. But then we've done the other stuff as well, and we've created what I would call white elephants. This is a 1,000-bed hospital at a cost of $1.8 billion. And it's totally over the top. If we look at what that money bought us per bed, that's gone totally pear-shaped in my view. And that is because of the funding system. It was what we call activity-based rather than population-based. Whereas the government now is changing the system to a population-based system. Means that they will literally say, you have a population of X wide, that means here's the amount of money for it, and you figure it out from there on onwards. That's another one, $1.7 billion in Adelaide, also again similar story, and this is one in the making at the moment on the Sunshine Coast, $2.2 billion. So we've just thrown money at the problem, and we thought that would make the problem go away, and it doesn't go away, because there's always the next one. And if we actually, I've done a lot of these studies for this state, and we actually need another 15 billion if we were to actually solve the problem by throwing money at it. We don't have 15 billion, we will never have the 15 billion in the next 20 years. So what has actually changed? Well, before, as Serge introduced, that the system in Australia is where the government is both the supplier and the regulator. In the past, they were also the owner of the assets, and that meant that the hospital operators really were just doing the maintenance, the basic maintenance. They've now set up these hospital boards with chair people, and they're now also responsible for their assets. So they now need to start strategically thinking, how do I get a new hospital in the next 30 years, if I need one? How long will this one last? Is this good money that I'm throwing after bad, etc.? So we're talking now, rather than maintenance management, we're talking now asset management. And they're responsible for finding those, setting the business cases up, and making sure that they don't go bankrupt along the way. So they're taking a quite formal approach. The government has legislated as well. They need to follow PAS 55, which is the British standard for asset management. And that means that there is quite a lot of actually structures and planning sitting behind that become extremely strategic about all of these other items. When you get all of these blending together and you put it in a pressure cooker with government, and then especially with the planning department, you can actually start achieving great things from an urban planning point of view. And we see that's now happening in all our major cities, where we start using our major hospitals, the 1,000-bed hospitals that are pretty old, that are spread out. They used to be 3 or 4 stories high. We're actually condensing them. We're going up to the new building heights, which are anywhere between 15 to 20, 30 stories in some areas. And that actually frees up quite a bit of land. And what we also realized is we've actually invested billions of dollars over the years in this area without leveraging that for an economic outcome, although we actually have a huge land holding. Now, I'm one of the first advisors to government that always says never sell a piece of land as government, but lease it for the next 99-year lease. And any bank in that part of the world will see a 99-year lease as actually a freehold title, and will give you full funding for it. So what we can do on the back of that is actually develop all the land around us, and that is for research institutes, for industries, even for housing, we have hotels, etc. coming onto these sites. And that actually starts making quite a nice cosmopolitan area, which gives us a revenue stream that then the board can use to invest again in their equipment and in their infrastructure. I won't go through the specifics of any of these ones that we've done, but basically out of all of that then comes a very clear plan, what we call the short-term plan for these hospitals, which really tells them, let's do up this part of the building, let's invest in this piece of infrastructure, and let's go and buy these new clinical equipments. So the broader government response there to the health and wellness, rather than just the Ministry of Health playing their own, really starts creating planning opportunities. The economical benefit is really that, and I need to speed up through this, is that we actually can really start planning with the players. And we're playing here between an industry that starts investing with this, that starts also underwriting research, etc., but also developing of new products. And in many ways, this organization, Prof, is actually doing this at a local scale as well, which is great to see that. And we're trying to do this at a higher level. Still, government, unfortunately, needs to be involved in that, but we're kind of getting them in this. This is called a triple helix model. You can look at that up. It's an internationally applied governance model that has proven to be quite successful. And out of that then really comes a development strategy which really unlocks different parcels at different times that funds the entire thing. And the economic development out of this is that we, like in this particular example, where we grew an employee base of 7,000 people into an employee base in the next 20 years of 25,000 people. So that is, in Belgium, we would call it a small city in many cases. And the development application here is then we're getting into development space. These are people who know what they do. They can actually access the funding outside of government and really draw that money in there. That was another example which I will just skip over, but that's a new research institute that is in the making, which is totally funded by the same approach actually of doing that with the land holding. So it is about creating alternative investment capacity through capturing the economic uplift. Solution, unlocking innovation, and I was going to go very quickly to 3 examples that I wanted to show you with our part of the world. The first one was the community healthcare centers. This is an example in Singapore, again another example of very highly dense part of the world, where in this particular facility it's a community health center which is totally not funded by the government. The government just takes a lease out, so it doesn't have to pick in the fork out any cash flow. The basement is just a car park. It is located next to the MRT, which is their public transport version of buses and trains. It has on the bottom there typical food courts that you see in Asia with all the eateries, etc., and then the restaurants on top. And then that's where we also find a medical center, which is just a tenant in it. Opposite there can be private health suites by doctors or specialists. We have childcare mixed in there. We have senior activities where all these come together. And then also an aged care tower. And typically there's 4 towers on this. So one of these towers is aged care. The other 3 will just be normal residential buildings. So the whole public is actually funded through a residential developer that provides all of this. That's just a section of it, of what it would look like. The next example is just leading by example, and what I want to show you here is Kutek Phuat Hospital in Alexandra Health District in Singapore. What you see here is the center of the hospital. You will see, where is it? I can only see the trees. That is the center of the hospital. They've actually turned the whole center as an outdoor space, and as you can see, people just need to walk through this outdoor space to get from one building to another. They've actually also turned the overflow of the stormwater drains into a waterfall supply where you walk past and you're walking through the rainforest really to get from one department to the other. The gym is actually a space that is accessible also for the staff, so before hours and after hours the staff can all use that. And the entry of the hospital, it actually looks very much like the porte cochere of a 5-star restaurant, hotel. And the beds, I won't go into bed design, a bit of a different system there, but really very, very well modern equipment, etc. What you see here is the rooftop. By building this hospital, displaced a huge amount of community gardens, which the elderly people were very upset about. So they've actually replaced these gardens on top of the rooftops. The elderly people came back, still do the gardening, and they all do that for free. And guess what? All the veggies that come out go straight in the food court downstairs. They cook it up fresh, and they sell it to the public. So it became a revenue stream for the people who use it. And it's really good food. It's not your usual hospital food. It's really great. And the last thing is that the buildings are very simple. You know, they just keep them as simple as possible, keep them as commercial, residential buildings, don't make them too fancy. And so this shot, you could just think these are 3 office towers that are sitting there, and it's just a hospital, which keeps the square meter rate down of these facilities as well. The very last one is about providing access of care, and an example that we did in Australia. In Queensland, you saw on the previous map, we're quite large. Queensland, Texas fits twice into Queensland. We have 168 health facilities, of which about 100 are really what we call remote and rural. I traveled quite a bit to Thursday Island, which is one of the dots on the top. It takes me about 2 days to get there just by flights and then boats, etc., just to get to the facility. So if it is that hard for a person to get there, it's much harder even to get a building there, to get builders there, to get materials there. So we came up with the idea, sorry I'm going the wrong way, we came up with the idea of providing a facility that we can make in the city and ship all the way out there, and providing the same level of access, the same level of building and quality to those people, because that was something that didn't exist in the past. Health was organized sometimes out of the back of a garage, so to speak. So we came up with this idea of prefabrication and chopping the building into modules that we could actually transport, and this slide actually shows you how this building is split up in modules. That's how we designed them into pieces. They're all conforming the road regulations, etc. So we were allowed to actually transport this on the roads. And then on the site, we would actually just bring this together by literally just rigging this together on site, and that worked as well for the building as for the building services. The other thing about this is that it was flexible. So a lot of our local communities change in population. Queensland is still a huge mining industry, so mines go up and down. The price of gold goes up, we see a huge population, 30,000, price goes down, and there's 500 people left in the town, etc. So we need to be able to scale these facilities up and down, which is a huge problem as well. So by doing this, we're actually able to puzzle various combinations together, and we can actually subtract and retract these buildings. So they were all made in a yard somewhere, they were all tested together, put on the back of a truck literally, put on site, and the end result, if you're inside, you wouldn't know any difference. This doesn't look, and the quality is exactly the same. And that was it. Thank you.